So um, I did this as more of like a poster presentation as if I was really there. So I did not do like a PowerPoint, do like PowerPoint slides. So I hope that it's not too small for everyone to see. But my name is Margot Debrabandere. I'm a fourth year OBGYN resident at Stamford Hospital in Stamford, Connecticut. And today I'll be presenting my research on immediate postpartum long-acting reversible contraception and its impact on short interval pregnancy from our community hospital's perspective. So to start off with some background, short interpregnancy interval, or short IPI, is defined as 18 months or less between a delivery and a subsequent conception. ACOG, our governing body, currently recommends or advises against an interpregnancy interval less than 6 months, but does recommend a discussion of the risks and benefits on a more individualized basis for repeat pregnancy sooner than 18 months. Short IPI is important because it is associated with adverse maternal and fetal outcomes, as well as a significant economic burden. Unfortunately, up to 70% of pregnancies in the first 12 months postpartum are unintended. And this is due to a variety of factors, including lack of postpartum visit attendance, as well as approximately a 40 to 50% rate of return of ovulation and return to sexual activity by 6 weeks postpartum. So this is where long-acting reversible contraception, or LARC devices, come into play. Studies have demonstrated that when they are placed immediately postpartum, or for a IUD, that means post-placentally, or for a Nexplanon, or the subdermal implant, that just means before hospital discharge. When this is done, it has been associated with a lower probability of a short interpregnancy interval compared to women who use less effective methods, such as short-acting methods like the pill or the patch or the injection. Because of this, ACOG has called for both institutional as well as policy changes to support their provision. And so in the state of Connecticut, Medicaid expanded coverage to reimburse immediate postpartum LARC in 2017. And our hospital, Stamford Hospital, has been providing immediate postpartum LARC to patients with Medicaid since March of 2020, since the creation of the Division of Family Planning at our institution. Without public programs like this in place, up to the rate of unintended pregnancy and abortion would be about 60% higher than they currently are. The objective of this current study is to assess the rate of short IPI between those receiving and not receiving an immediate postpartum LARC since the implementation of this institutional change at our hospital. So taking a look at our methods, this was a single institution retrospective cohort study. We included women with Medicaid who delivered at 26 weeks or more gestation at Stamford Hospital between March of 2020 to March of 2023 and received their prenatal care at our federally qualified health clinic known as Optimus Clinic. The reason for the 26 weeks is because that is the level of, or that is the gestational age at which our NICU is able to start providing resuscitation. And then our number for meeting this inclusion criteria was 1,032 patients. Our exclusion criteria was essentially women who had private insurance who did not receive their prenatal care at our federally qualified health clinic. We did also further exclude women who chose permanent sterilization as their form of contraception. So that number was 176. So then when we take a look at our two cohorts, our target population, which was those who chose an immediate postpartum LARC device, including a levonorgestrel IUD, a copper IUD, or a subdermal implant, or the Nexplanon, prior to hospital discharge. And then our comparison population, we called no immediate postpartum LARC. And so this was a much broader category that included women who chose no contraception at all, women who chose a short-acting method prior to hospital discharge. And at our institution, we offer both the progestin-only pill as well as Depo-Provera prior to hospital discharge, or women who chose any method after discharge, but within 12 weeks postpartum. So this can include those short-acting methods that I mentioned, but it can also include a LARC device initiated once again after hospital discharge, but within 12 weeks postpartum. We submitted a data request to our business analytics department using various CPT and ICD codes, and then also performed manual chart review to basically identify all of these variables listed here for patient characteristics, including demographics, pregnancy delivery characteristics, and the choice of postpartum contraception. Our primary outcome was a new documented pregnancy within 18 months of delivery. And our secondary outcomes included rate of postpartum visit attendance within 12 weeks, rate of continuation of contraception at various time points, including both 6 and 12 weeks and 12 and 18 months, and rate of IUD expulsion and replacement. Statistical analysis was performed by our statistician here, and we used a p-value of less than 0.05 to determine statistical significance. So turning to the results, with regards to demographics and pregnancy and delivery characteristics, there was no statistically significant difference in age, ethnicity, employment status, marital status, gestational age, mode of delivery, BMI, or other comorbidities such as hypertension and diabetes, as well as number of prenatal care visits. However, there was a statistically significant difference identified in race, gravidity, and parity between the two cohorts, as we can see in Table 1, which is the first table on the left here. So this demonstrates that African American patients had almost double the odds, or I'm sorry, slightly greater than double the odds of being in the no immediate postpartum LARC group. And then when we look at gravidity and parity, we see that those with a lower gravidity and a lower parity were also almost double the odds of being in the no immediate postpartum LARC group. When we turn to the two charts below this in Figure 1, this demonstrates the type of contraception that was initiated prior to hospital discharge, as well as the type of contraception initiated after hospital discharge, but within 12 weeks postpartum, with the type of contraception initiated prior to discharge on the left and the latter group on the right. So when we look at this, we saw that actually the type of contraception initiated was quite similar between the two groups, with Depo-Provera being the most common form of contraception chosen, whether that was before hospital discharge or after hospital discharge, followed closely by the pill as well as the Nexplanon. When we took a further look at, in terms of who did not initiate contraception postpartum, it was about 1 in 3 individuals chose no contraception at all at the time of hospital discharge. And then from that, another 1 in 3 did choose to initiate contraception within 12 weeks postpartum. And lastly, the table in Table 2 on the right demonstrates our primary and secondary outcomes. So we can see that there was a statistically significant difference in the rate of short interpregnancy interval between our two cohorts, with a rate of about 6% in the immediate postpartum LARC group and about 25% in the no immediate postpartum LARC group. In terms of IUD expulsion, it was about 9.52%, which is consistent with prior studies, which quote a range of about 10 to 27% for IUDs placed post-placentally. And then of those that did expulse, about a little bit shy of 1 in 3 individuals had it replaced. You can see that these numbers become smaller and smaller because there was loss to follow-up, which definitely is one of the limitations of this study. In terms of postpartum visit attendance rate, it was similar between the two groups at about 90%. And we did find that this is much higher than the national average, which is about 40%. And lastly, can see that there was a statistically significant difference at 6 weeks, 12 weeks, and 18 months for the immediate postpartum LARC group. There was no statistical significance at 12 months, although there was still a higher rate of continuation of contraception for the immediate postpartum LARC group. So ultimately, this study has demonstrated that increasing availability of immediate postpartum LARC and implementing a program like this at a community hospital like ours could be a promising approach to lowering the rate of short interval pregnancy in this type of population. Thank you so much.